Great, everybody. Well, thanks for joining us on this beautiful May 1st. Today, we're going to be talking about a fundamental topic for those in advanced heart failure and transplant cardiology. I'm very happy to welcome our transplant pharmacist from Yale New Haven Hospital, Stephanie Stocker, who's going to take us through immunosuppression. Stephanie, thank you so much.
Thanks, Dr. Beasley. I packed kind of a lot in for a half hour, so run through things pretty quickly, and hopefully slides and videos will be available if folks want to reference things later. But I'm Stephanie. I do not have any disclosures, but we will definitely be talking about off-label use of quite a few medications during this presentation. And the main goal with this is to review mechanism of action, side effects, potential drug interactions of our immunosuppression medications. And we'll go a little bit deeper and maybe talk for a few things on why we would pick necessarily one medication over another within drug classes. So, we know that medications are key to transplant survival. We saw with the use of cyclosporin, tacrolimus, median survival in heart transplant has increased significantly. And it continues to be a really important factor in survival when we think about medication adherence and things like that. This is our kind of traditional 3-signal model for the activation of T cells. And we're going to come back to this over and over again. So I'm going to take a few minutes to review it. Let me see if I can get my pointer in here. So when we think of T cells being activated, typically this happens with an antigen presenting cell presenting an antigen to the T cell and it binding the T cell receptor. In order for this signal 1 to be effective, you need signal 2, the binding of CD80 and 86 to CD28, which is co-stimulation. And then this sets off a cascade of events, which ultimately results in transcription of IL-2 in the nucleus. IL-2 then binds here at CD25 and goes on to activate the cell cycle and T cell proliferation. And so when we think of immunosuppression after transplant, the vast majority of our immunosuppression agents, and typically our goal is to prevent activation and proliferation of T cells. And we target a variety of different areas within this T cell model. So nowadays we try to use more medications at lower doses that are a little easier to tolerate for patients, targeting different spots in the T cell activation pathway. And every patient is a little bit different. We know that more medication results in more adverse effects, more side effects, more infections, malignancies, but less immunosuppression puts patients at risk for rejection or may impair their graft function. And so for each patient, the goal is kind of to find that balance point between these two. And patients may be exposed to immunosuppression at a variety of different points around their transplant. We're not going to talk about desensitization, but they may receive immunosuppression at the time of desensitization. Some patients receive induction therapy, so larger doses of immunosuppression at the time or around the time of transplant. They all should be receiving maintenance therapy, oral, mostly medications that prevent rejection as time goes on. And then if they have a rejection episode, they may be exposed to additional immunosuppression at that time point. We're going to start with the induction therapy. So induction therapy are those larger doses of immunosuppression given around the time of transplant with the main goal of reducing the incidence of early acute rejection. We don't have a lot of great data for it in heart transplant, but sometimes we borrow from our abdominal organs, and we will sometimes using induction therapy to allow us to delay the initiation of calcineurin inhibitors, especially in patients that may have some renal dysfunction going into transplant. And the induction therapies that are available can be divided into 2 broad categories: our T cell depleting therapies and then our non-depleting therapies. Our T cell depleting therapies include anti-thymocyte globulin or thymo, and this is a polyclonal antibody. We traditionally think of it as targeting the T cell receptor or CD3, but it's it's monoclonal antibodies. There are many drug targets here on a variety of different cells. We're not just looking at and targeting T cells here with this medication. And then the other option is alemtuzumab or Campath. It's not used very often in heart transplant, but this is a monoclonal antibody against CD52. And again, it's found on a variety of different cell lines. And so we're not just targeting T cells with these therapies. And because they're T cell depleting, they cause T cell lysis. And the big thing we see with these medications is a cytokine release syndrome and infusion reactions. And so unless they're being given in the OR, typically these medications need to be given with pre-medications like Tylenol, Benadryl, and steroids. Basiliximab or Simulect is a monoclonal antibody against CD25, and this is a non-depleting therapy, so it's much better tolerated. It's usually given in 2 doses, post-op day 0 and 4. And I think the big takeaway with induction therapy is while the drug half-lives are short, the duration of action is much longer. So when we look at thymoglobulin, the drug half-life is about 2 to 3 days. When we look at alemtuzumab, it's about 11 hours. But this graph here, where we're looking at mean lymphocyte count, shows that the counts dropped very quickly within 7 days of receiving either medication, and it took upwards of 6 months for counts to recover. And so when we choose to give these medications as induction therapy, these medications impact the immune system for much longer than just what our drug half-life is. One kind of little pearl about thymoglobulin is it does come in 2 formulations. You're not going to see ATGAM very much. ATG is the rabbit-derived formulation, and so this is a variety of antibodies against human T lymphocytes. ATGAM is the equine-derived version. So the one kind of place you might see this is if you have a patient that had a rabbit allergy or a horse allergy, they may actually tolerate one formulation over the other. But the standard of care really is to use the ATG, the rabbit formulation. And the reason that's the standard of care is there's quite a bit of renal transplant data that shows when using it as induction therapy, there are lower rates of biopsy-proven acute rejection and higher survival in renal transplant population. And so it's good to know that it exists, but it's not something that you're going to see very regularly. The other pearl to kind of take away with thymoglobulin use is serum sickness is one of the potential side effects. So serum sickness is the formation of complexes between preformed antibodies and then the medication itself. And what is really interesting is this onset is usually about 1 to 2 weeks after we give the drug. And so classically, patients are either discharged, or if they're still admitted, we're probably not thinking about a medication that we administered several weeks ago, 2 weeks ago, when patients develop rash, fever, and polyarthralgia. Can be particularly painful. So it's not a common side effect, but it is something to kind of tuck away, and does happen from time to time with thymoglobulin specifically. And really with induction therapy, this is still a very controversial area in heart transplant. What we have up on the screen is a meta-analysis of 8 randomized control trials and 3 observational trials that suggest that there's lower rates of moderate to severe rejection when using rejection, but then when using induction, but there were higher rates of malignancy, and there didn't seem to be a mortality benefit. There have been some registry studies that have suggested there may be a mortality benefit, but this is definitely still a controversial area, and practice is very different from center to center. So this data is getting a little bit older, 2019, but this came out of JHLT and really shows that only about 55% of transplants we're getting induction, most of them with basiliximab, but some of them with thymoglobulin, and again, alemtuzumab is not as commonly used in heart transplant. So really kind of all over the board in terms of induction use around the world. For the remainder of the session, we're going to talk about maintenance immunosuppression. So I'm going to start with the big 3, and then we'll kind of talk about some alternative immunosuppression options for patients. So we'll start with calcineurin inhibitors, which is really our backbone of immunosuppression. Our 2 options are tacrolimus and cyclosporin. And so tacrolimus here is your FK506. Both of these medications bind to substrates. So tacrolimus binds FK binding protein and cyclosporin binds cyclophilin, and both of these inhibit calcineurin. Calcineurin is an enzyme that dephosphorylates NFAT. Once it's been dephosphorylated, it can enter into the nucleus, and then it promotes gene transcription of IL-2, which then promotes T cell activation. And so by inhibiting calcineurin, we can effectively inhibit IL-2 production and T cell activation. And they come in a variety of different formulations. And the take home from this slide is these formulations are not all the same. And it's really important to keep a patient on the same formulation and not to accidentally switch someone. So tacrolimus comes as an IR capsule prograph. That's what it's been for a long time, has been available. Invarsus is the extended release tablet formulation, and we're starting to see this used more and more. It is not a one-to-one conversion. So patients actually require lower doses, the extended release formulation, when they're switched over. And then Astrograph really isn't used very, very often. And this PK curve that you're seeing here on the slide, the green here is your IR prograph, the blue is your Invarsus, and you can see that when these curves are normalized to AUC, you have a lower Cmax. Many of the side effects we associate with calcineurin inhibitors are associated with peak levels in their Cmax. And so there's been some data to show that Invarsus may have lower rates of some adverse effects. So it's becoming more commonly used. And then cyclosporin is still used, and there are kind of two different types. There's the unmodified and the modified microemulsion. The unmodified version is more dependent on bile for absorption. It's got lower bioavailability, and there's a lot more interpatient variability and variability from day to day within a patient in terms of absorption. And so the vast majority of cyclosporin that's being used these days is the modified microemulsion version. So unless you have someone that was transplanted 30 years ago, you probably don't have too many people on Sandimmune anymore. And calcineurin inhibitors can be given IV. If you do this, I really hope that you have a handy transplant pharmacist nearby, because it can be kind of challenging to convert folks over. You're bypassing all of the metabolism that occurs in the gut. There's a lot of CYP3A4 in the gut. And so you're kind of skipping past that. And there's a lot of variability from patient to patient and what the appropriate conversion ratio ends up being. Additionally, this drug, both of the drugs actually adhere to lines and tubing. And so if you change your lines out, you can actually change your drug concentration. It's a continuous infusion that requires a dedicated line that you can't draw a level off of, because the drug adheres to the tubing and that changes the level that's drawn. And we think of these as being nephrotoxic, but it's put in a chromophore vehicle with castor oil and alcohol. And so it's even more nephrotoxic in IV form. And a standard dose administers like 15 to 20% of a standard drink. So we try to avoid it in pregnancy. So most centers try to avoid IV calcineurin inhibitors as much as possible. One of your other options for folks is sublingual tacrolimus, and you still get some high variability because you're bypassing theoretically the gut metabolism, but it's much easier to convert folks than the IV formulations. And most centers are using a 2-to-1 conversion for this, but there's still quite a bit of variability, and you have to kind of monitor levels really closely. And these two drugs have fairly similar side effect profile. Tacrolimus is really known for its neurotoxicity, hyperglycemia, much more post-transplant diabetes, and alopecia. And cyclosporin is known for its hypertension, its hyperlipidemia, gingival hyperplasia, and hirsutism. So some similar side effects, but also quite a few differences. When it comes to the nephrotoxicity, a lot of times we think of the acute toxicity. So when TAC levels are high, we see constriction of the afferent arteriole, reduced blood flow to the kidney, and we see a bump in creatinine. And that is typically reversible when we reduce the dose of a calcineurin inhibitor. It's also the same location that's impacted by NSAIDs. So if your transplant pharmacist gets all worked up when you have a patient on an NSAID, it's because they're literally both constricting the same arteriole here. And then you also see chronic, irreversible nephrotoxicity, which usually happens over years having patients on a CNI. And this is characterized by tubular atrophy, interstitial fibrosis, and this is, again, not usually reversible. When it comes to drug interactions, this is probably one of the reasons transplant pharmacists have a job. There's so many drug interactions with these medications. Both medications are CYP3A4 substrates, and we've got a lot of interactions with that metabolism pathway. Both are PGP substrates. What I will point out is that cyclosporin is also a PGP inhibitor. So cyclosporin impacts a lot of drug levels that tacrolimus doesn't. If you think about, for example, statins, patients have higher statin levels and usually don't tolerate them as well when they're on cyclosporin because of the PGP inhibition. And when we compare the two medications, what we have seen, this is a randomized control trial where patients were randomized 1-to-1 between tacrolimus and then cyclosporin microemulsion. We saw a reduced rates of biopsy-proven acute rejection in our tacrolimus group, but there really wasn't a significant difference in mortality. So we don't think there's a huge mortality benefit to using cyclosporin, but we do think that there's a huge benefit from a rejection standpoint. And so it is standard of care to use tacrolimus first. Every center in the country is doing it, but cyclosporin is still an option and is available. Our second group is our anti-metabolites. This includes mycophenolate and azathioprine. And mycophenolate, as you can see here, it's a prodrug. It's converted to mycophenolic acid, and then it reversibly binds IMPDH, and it blocks purine synthesis. And our lymphocytes don't have this salvage pathway for purine synthesis. So it is a way to inhibit lymphocyte proliferation. This is kind of a busy slide. What I want you to take away from this is that mycophenolate undergoes enterohepatic recirculation. So because it gets recirculated, we tend to see this biphasic pharmacokinetic drug concentration. And we think that this is why it is really difficult to correlate any sort of mycophenolate level with any sort of outcome. So we've never been able to consistently show mycophenolate levels drawn at any time point correlate with clinical outcomes. And it likely has to do with this enterohepatic recirculation and difficulty kind of measuring levels. So most centers can draw a mycophenolate level, and it can be a very useful tool for monitoring adherence, for example, but it's not great in terms of assessing if a patient's at higher or lower risk for rejection. Our other anti-metabolite option is azathioprine. Azathioprine is metabolized into 6-mercaptopurine, which integrates into nucleic acids, and it ends up inhibiting RNA and DNA protein synthesis, and it inhibits lymphocytes. And one of the big things to take away here is one, xanthine oxidase is a really important enzyme in the metabolism of 6-mercaptopurine. And so when we put patients on allopurinol or febuxostat that inhibit xanthine oxidase, we end up with more drug being shifted down into toxic metabolic pathways. And so we see a lot more side effects. We see a lot of leukopenia, and there's been a lot of case reports of patients accidentally being put on these two medications by different providers, resulting in severe leukopenia and even death sometimes. So this is like #1 drug interaction to remember with azathioprine is that, typically we avoid, some centers will not put these two together. If you use them, they have to be used in very low doses, and you have to monitor CBC very closely with initiation. And then TPMT is another really important enzyme in metabolism, and this we can actually check the activity of. So patients that are TPMT deficient or have lower TPMT activity, again, you're going to have the metabolites pushed down a toxic metabolic pathway. And so they're at much higher risk for the adverse effects and toxicities that come with azathioprine. And so this is something that we can actually check and we can monitor before we start patients on it. When it comes to adverse effects with our antiproliferatives, mycophenolate is really known for its GI side effects, nausea, vomiting, diarrhea, and it can induce birth defects. So we'll talk about that a little bit. Both of them can cause bone marrow suppression. With azathioprine, we can check TPMT to kind of give us an idea, and NUDT15 too, as well as like a newer one that most centers are checking to assess risk of toxicity. And then it's kind of unique factor is that it can cause some hepatotoxicity. And so typically we'll monitor LFTs with initiation. Because of all the GI side effects with mycophenolate, myfortic was developed. So the idea with myfortic was this is an enteric-coated version, and it may help with all of these GI side effects that we see with mycophenolate. And what you're seeing on this slide is pulled from renal transplant literature, but effectively this compared the use of CellCept and myfortic and didn't find any difference in adverse effects. There were slightly fewer patients numerically that required dose changes for GI side effects on mycophenolate, but it wasn't statistically significant. So, and this kind of makes sense because while some patients will take the medication and within an hour have an upset stomach or some sort of GI side effect, really a lot of times the diarrhea we associate with the drug's actual toxic effects on crypt cells and GI cells and sloughing in the GI tract. And so coding this is probably not going to impact it because it really is the mechanism of action that's impacting and causing these side effects. So it certainly is an option that's available, but it's not well supported by literature to have lower GI side effects. And I will hit on the mycophenolate REMS program. I don't know if any of you were at ISHLT this week, but there was a presentation from someone from the Transplant Registry International, and she presented on a big group of 104 heart transplant recipients that had pregnancies. And one of her take-home messages, and now one of my take-home messages, is that 42% of the pregnancies were unplanned and on mycophenolate. And so our REMS program does not seem to work very well. So any patients that are young of childbearing age need to be on some form of contraception. And what is even more challenging is mycophenolate may reduce blood levels of some of the oral contraceptives. And so if patients are taking oral contraceptive pills, they likely need to be on additional form of birth control. And so the REMS program is great. There's lots of patient information out there, but just knowing that this is a really important factor for any of our young women who are receiving mycophenolate. And when it comes to choosing between the two agents, we have seen kind of time and time again that mycophenolate likely has lower mortality rates. It has lower rates of acute rejection, lower rates of chronic rejection and CAV. But it does come with those higher GI side effects. So mycophenolate tends to be the agent of choice, with azathioprine as an option for folks who don't tolerate it. I am not going to spend a lot of time talking about steroids. I am guessing almost everyone on this call has a lot of experience with them, but they are one of our medications that we use to suppress the immune system. And there are a lot of different mechanisms that have been thrown out there. So one of which is that it binds heat shock proteins that translocate to the nucleus, and then they bind a glucocorticoid receptor and inhibit the transcription of IL-2. But that's likely one of many. There's likely a lot of different mechanisms going on here. And every center is going to approach steroids a little bit differently. I think the big take-home message is there's a ton of side effects. And so what we can do to minimize our steroid use, we do try to do. Most centers will start on higher doses and taper down. A lot of centers will try to get patients off steroids altogether once they're farther out from transplant due to kind of the long-term side effects that come with being maintained on steroids. So I'm going to spend a little bit more of our time on some of our alternative immunosuppression agents. So mTOR inhibitors are kind of our big next line agent. Sirolimus and everolimus are our two options. They form complexes with FK binding protein that binds mTOR, and mTOR is a key enzyme in our cell cycle. And so we're effectively inhibiting or arresting cell cycle at our G1 phase. The big take-home message for these are they have a really long half-life. So when we make dose changes, or if we start something that interacts with them, with sirolimus, it's going to take almost 2 weeks for us to see our new steady state level. With everolimus, it's a little bit shorter, more like 1 week. But these medications can be a little bit challenging to manage just from the aspect of once we make a change, it takes a long time to see that new steady state concentration. The other challenging piece is these medications have really high discontinuation rates in renal transplant trials, heart transplant trials. There's a lot of side effects that come with these medications. So the top one, delayed wound healing, there's a black box warning for increased mortality in heart transplant. And this is likely just related to early post-transplant use. So with some exceptions, the vast majority of centers are waiting at least 3 months after transplant to initiate therapy with mTORs just because of the delayed wound healing. Hyperlipidemia, specifically hypertriglyceridemia, can be a barrier to using this medication. We see proteinuria, we see oral ulcers. Oral ulcers can sometimes be managed with a clobetasol gel course and then reducing the dose or the level of your mTOR inhibitor. But sometimes it can actually prevent us from being able to use these. And they're, of course, an opportunity for infection. Acne, lots of dermatologic side effects with these. Interstitial pneumonitis is a huge issue. And then we can see edema with them as well. So kind of like a wide variety of side effects that are unfortunately fairly common with mTOR use. And side effects are somewhat similar to calcineurin inhibitors. So really not a ton of differences. Again, your big difference is it's going to take a lot longer to see the effects when something started or stopped. The other thing I guess I will mention is there's actually in the package insert a note that sirolimus and cyclosporin interact, because remember, cyclosporin is a PGP inhibitor. And so there's a recommendation to administer them 4 hours apart. Most centers do not follow that because logistically it's nearly impossible to get drug levels on 2 different medications that are given 4 hours apart. So typically we'll administer them together, but to take that, that interaction into account. And why would we use this medication if it delays wound healing and it comes with all of these side effects and it's discontinued frequently in studies? Because it may reduce rates of CAV. And so we think that early sirolimus, being defined as less than 2 years, is probably best. Here's your early sirolimus line in terms of preventing CAV-related deaths. So there may be a huge benefit in heart transplant to using these medications, but you can't use them too early. There's delayed wound healing, and then there's also higher rates of rejection. And JHLT actually just came out with published a study earlier this year that showed that time from transplant to initiation was one of the big factors that led to or predicted, I should say, rejection in heart transplant. So use them early, but not too early. And then last, I'm really not going to spend a ton of time on this. Belatacept is not standard of care, but I think it's going to be the next big thing. We're going to start seeing more and more of it. It's a co-stimulation blocker. It blocks CD80 and 86. It's unique because it's in a once-a-month IV infusion. It doesn't have any known drug interactions. Infusion reactions are really rare. So a lot of really good things about it, but it does come with a black box warning for increased risk of PTLD, especially PTLD involving the CNS in patients who are EBV negative, so that without any known immunity to EBV. So you really only use this in your EBV positive recipients. In the kidney transplant data, it's been shown that this may improve long-term renal function in a CNI sparing regimen. And they have some 7-year data to show that it improved graft survival and patient survival, and may reduce the development of de novo DSAs. So there's a lot of desire to use this in the renal transplant population, and we're starting to see a little bit of use in the heart transplant population. There's 2 big kind of experiences that have been published with different dosing strategies. mostly using it in highly sensitized patients or as a renal sparing regimen with a reduced CNI. Especially in the second group, a lot of these patients were on a 4-drug regimen. So really in heart transplant, we're not at the point where I think we're successfully using it in a CNI-free regimen. There were some high rates of rejection in those folks, but our 4-drug regimen resulted in high rates of infection, and 20% of patients were discontinued off of it. So I don't think we really know where the place in therapy is for belatacept yet, but I would be remiss if I didn't at least include it in the presentation, because I do think it'll probably be a future option for our patients. That was a ton of information in our time. Sorry, I went a little over, Dr. Beasley, but I'm happy to answer any questions.
That was great, Stephanie. Thank you. Very, very informative and great presentation. Does anybody have any questions out there for those that are on the call? I was just wondering in regards to CellCept and Myfortic, is there a huge price difference between the two? Is that why we tend to use CellCept more than Myfortic?
Yeah, it can be a little bit more difficult to get Myfortic covered by insurance. It almost always requires a PA. And then some patients are still having some coverage issues after, even after the PA is done. So it's mostly like a medication access. And then just because it didn't have like great data to show that it has lower rates of GI side effects, a lot of centers are just kind of using it if they need to. But that's kind of been our experience with it. Yeah.
And then do you have any like clever hints about transitioning from one drug class to another? Like, let's say if you are wanting to transition someone from a calcineurin inhibitor to an mTOR inhibitor, or some other change that you might. I mean, how do you go about doing that? Or I guess it's any hints or tips for that type of practice?
Yeah, truthfully, converting patients, I feel like, is more of an art than a science sometimes. I do a lot of medication overlapping to try to prevent patients having a period of time where they're at risk for rejection if I was to underdose them. And then usually it's kind of a cross taper if you're doing mTORs, especially because the half-lives are so long. And so sometimes I'll kind of reduce immunosuppression a little bit while I initiate mTOR. An mTOR. I may even get a drug level after a week, knowing that it's not at steady state, just to kind of see where we're at. And then I kind of taper their whatever agent we're taking off as drug levels come up. So.
Hey, this is Pranav on the Heart Failure Fellows. I had a question. First of all, a great talk. Do you alter your immunosuppression, I guess, regimen for like young versus old, or is there any data that supports kind of different immunosuppression regimen for younger people versus older people?
That's a really great question. Traditionally, we think of our younger folks as requiring more immunosuppression. We don't have anything in our protocol that says, at this age cutoff, we change their immunosuppression in this way. I will say it does factor into conversations in a patient-specific manner. And I don't know if you were at ISHLT, but there was a conversation about this at one point because someone was showing the data, some data that patients who are older at lower risk of rejection. And they asked the same thing. They said, "Oh, now that you have this data, have you altered your protocol in any way?" And they hadn't yet either. So I think we're still kind of figuring out how to, what would you use as a cutoff specifically, and what would you alter? Probably your anti-proliferative, but we aren't per protocol doing any adjustments at our center, at least.
Thank you.
Great. Well, thanks so much again, Stephanie. A fantastic talk, and thanks for everybody for joining. Everyone have a great rest of your day.